Hello everyone, my name is Nason Wise. I'm one of the PGY1 acute care pharmacy residents at Moses Cone Hospital this year. And the purpose of the following PowerPoints is going to be to go through the different classes of antibiotics one by one. Some IV drugs have been included as well, just to make sure you're aware of them, but we'll focus in on the oral formulations. This first class will go through one of the oldest medication classes, the beta-lactams, which is named after its chemical structure. This class includes penicillins, cephalosporins, and carbapenems, and these agents all work on the cell wall, which we'll dive into deeper on the next slide. It's also important to note that within each class, the likelihood of allergic reactivity shared between penicillins or cephalosporins and carbapenems is innately pretty low. So really only avoid cephalosporins and carbapenems in a penicillin allergy if it's anaphylaxis. There are many drugs in the beta-lactam class alone, so the best way to keep them straight is to group them into classes and learn the characteristics of each class. These classes include the penicillin, cephalosporins, and carbapenems. In addition to the one monobactam antibiotic we have called aztreonam. These medications all work by binding and inhibiting the penicillin binding proteins in the bacterial cell wall, leading to lysis and death of the bacteria. The spectrum ranges pretty widely from very gram-positive coverage to very gram-negative coverage. And then anaerobic coverage kind of varies with each generation. There is never any atypical coverage just because atypical bacteria don't have a cell wall, so the mechanism is kind of innately ineffective. On each of these slides, the dosing will be listed in the graph at the top. First up, we have our natural penicillins, which includes penicillin G and penicillin V. Pen G is only available IV and IM, and it's dosed in million units, while Pen V is taken orally and is dosed in milligrams. Penicillins have great strep coverage, but they also cover some other bugs really well, like Treponema pallidum, which is better known for causing syphilis, and also Neisseria meningitis. It has variable activity to strep pneumo and enterococcus, meaning that you really shouldn't use that empirically with those organisms. And as far as staph goes, it's hardly ever effective because staph quickly develops resistance against these penicillins. So what do you think? Is it a good empiric drug or no? The answer is probably no. This should be reserved for more targeted therapy when you have one pathogen likely suspected, like strep throat per se, or syphilis, and or targeted therapy based on cultures. Unlike the previous group of penicillins, the anti-staphylococcal penicillins were designed to cover staph well. Because they have the ability to protect against penicillinases. It's important to realize that these medications cover MSSA, not MRSA. Dicloxacillin is the only orally available agent in this group. Nafcillin and oxacillin are used interchangeably based off hospital formulary, but they are IV medications. One important thing to note with this medication class is that the IV formulations contain a lot of sodium, so they can cause heart failure exacerbations or general hypernatremia, whereas these agents can also lead to acute interstitial nephritis, which can reduce kidney function. They aren't renally dose adjusted themselves, though. The aminopenicillins include ampicillin and amoxicillin. Ampicillin is available IV, IM, and PO, but the bioavailability and GI side effects are so bad PO that it's essentially just use IV. These two drugs both cover strep and enterococcus very well, but they don't have any activity against Staph aureus. They do have some gram-negative coverage, kind of extending out into the Haemophilus influenza, Proteus, and E. coli realm. But it's important to remember that H. flu and E. coli can produce penicillinases, which would lead to resistance in these medications. Because of this coverage, it's a drug of choice for otitis media, strep pharyngitis, and AMP-sensitive enterococcus. But due to the fact that it doesn't cover Staph aureus, its use is limited in skin infections. Next, we have the aminopenicillins and beta-lactamase inhibitor combination. Amoxicillin is paired with clavulanic acid, and ampicillin is paired with sulbactam. These work by using the beta-lactamase inhibitor to kind of act as a decoy to the beta-lactamase resistance mechanism that the bacteria produce. Those kind of destroy the beta-lactamases and allow the aminopenicillins to do their job well. This kind of extends the coverage to MSSA and also to some more gram-negative bacteria like Klebsiella. In addition to that, the beta-lactamase allows anaerobic coverage as well. So whenever you see a beta-lactamase inhibitor, know that it also has anaerobic coverage. These medications do not cover Pseudomonas, so it's important to remember that if you suspect hospital-acquired infections or Pseudomonas in any way, that these are not the agents of choice. The last class of penicillins is the extended spectrum penicillins, and this class is really similar to the last slide, but basically adds Pseudomonas coverage. The main agent in this class is Zosyn, or piperacillin tazobactam, and it's really only a broad spectrum antibiotic used in hospitals. There are a ton of cephalosporin agents available, and it can kind of seem overwhelming at first, but it's best if you group it within classes. And it's a general rule of thumb, going from first generation to fourth generation, you lose gram-positive coverage and gain gram-negative coverage. That rule is kind of upset a little bit with the fifth generation, which goes back to gram-positive, but it's kind of like a check mark if you see the trend there. The first generation cephalosporins to remember are cephalexin, cefadroxil, and cefazolin. Cephalexin and cefadroxil are oral agents, whereas cefazolin is only IV. The spectrum activity, it's most known and most used for its MSSA coverage, but it also covers strep and some gram-negative bacteria like Proteus, E. coli, and Klebsiella. It's important to note that none of the cephalosporins cover Enterococcus, so they really shouldn't be used if that's suspected. There are some differences compared to the anti-staphylococcal penicillins. It's less frequent dosing, which is an advantage, and one of the reasons why cefazolin is used a lot more often. It does not cross the blood-brain barrier as well, so if you suspect CNS infections like meningitis, it's usually preferred to use nafcillin or oxacillin. It may be used in penicillin allergic patients as long as it's not anaphylaxis. And it's most clinically seen in MSSA infections, skin infections, UTIs, and surgical prophylaxis. Second generation cephalosporins trade some gram-positive activity to cover more gram-negative bugs like E. coli and H. flu. Because of this, they're most commonly used for upper and lower respiratory tract infections, although cefoxitin and cefotetin are commonly used for GI prophylaxis because they have anaerobic coverage. These oral agents are not commonly used because they don't offer as much of an advantageous coverage compared to the first generations, and they're more expensive and less widely available. The third generation cephalosporins overall follow the trend of losing gram-positive coverage to give a little more gram-negative coverage. The big outlier in this class is going to be ceftazidime because it has no gram-positive coverage and adds Pseudomonas coverage. So if you're outpatient, you likely won't be using this medication, but it's important to note that if you want broad-spectrum coverage, including Pseudomonas, you'll have to add another agent to add the gram-positive coverage. This has a lot of great oral options available, including ceftenir and cefpodoxime. These medications cover Salmonella, Proteus, E. coli, Enterobacteriaceae, Klebsiella, and Serratia pretty well. This kind of lends it to be a great agent to use for upper and lower respiratory tract infections, UTIs, and skin infections as well. The fourth generation cephalosporins go all the way to the negative end of the spectrum. They still cover gram-positives like strep and MSSA. Not as well as cefazolin, but they do cover it. It adds, however, great gram-negative coverage like Pseudomonas. This is an IV agent only, cefepime, and it's usually used for broad spectrum antibiotic use when Pseudomonas is concerned. The only fifth generation cephalosporin is ceftaroline or Ceflaro. It's only available IV and kind of flips the spectrum back to gram-positive, including MRSA. It has gram-negative coverage similar to ceftriaxone, meaning that it does not cover Pseudomonas. Its clinical use is most commonly seen in patients who are very sick from skin infections, community-acquired pneumonia, or endocarditis. The carbapenems are only available as injections, but they have some of the broadest spectrum of action of all the antibiotics. Some things that they have in common are that they do not cover MRSA or atypicals. However, not all carbapenems are created equally. Ertapenem has some gaps in coverage when compared to the others. It doesn't have any activity against Pseudomonas, Enterococcus, or Acinetobacter. However, one advantage of ertapenem is that it's dosed once daily. Imipenem and meropenem are similar to each other in that they do cover Pseudomonas, Enterococcus, and Acinetobacter, as well as a lot of other gram-positive and gram-negative organisms. These drugs are pretty well tolerated. They do have good CNS penetration, and because of this, they have been known to cause seizures. Imipenem carries the highest risk for this. The big takeaway of this class is that it's one of the broadest spectrum antibiotics available and should really be reserved for use in patients who have multi-drug resistant organisms. Carbapenems do not cover MRSA or atypicals, so if you suspect those organisms, you'll need to cover it through a different antibiotic. Aspirinum is the only drug in the Monobactam class, and we'll touch on it briefly because it's only available IV. It is generally reserved for patients who have penicillin allergies of anaphylaxis, and because it's not cross-reactive at all. It is really reserved for broad-spectrum IV therapy, and it does not cover gram-positive MRSA. So generally, it's vancomycin is added when used for broad-spectrum coverage. This really is kind of expensive and should be reserved for patients who require broad-spectrum gram-negative therapy and allergic to penicillins. Beta-lactam medications are generally well tolerated, but there are some adverse events that come along with their use, such as GI intolerance, hypersensitivity reactions, and the risk of seizures. But seizures are mostly a carbapenem side effect or cefepime. Another very common thing to encounter in practice is patients who have a penicillin allergy. About 90% of patients with a penicillin allergy do not have a true allergic reaction when given an immunologic challenge. A detailed history is really important to determine the nature of the allergy and the risk of exposure to other beta-lactams. There are ways to reconcile penicillin allergies based on their histories, such as skin testing or direct oral challenges. As you can see, the cross-reactivity of the penicillins with other beta-lactam classes like carbapenems and cephalosporins is no more than 2%. The allergic reactions that are most important are what specific drugs has your allergy been to, rather than just penicillins overall. Do you remember your reaction? Did you have angioedema, hives, or anaphylaxis? What happened? Did you get intubated, etc.? How long after taking the drug did it happen? Because timing tells us whether or not it was a true penicillin allergy. What did you and or your physician do? Did you go to the ED? Did you just stop taking the drug, etc.? And then what other antibiotics have you tried since then that may show you could tolerate a cephalosporin? Cross-reactivity is primarily dependent upon side chains of the antibiotics, and you can look at each side chain to see the kind of likelihood of cross-reactivity. The most common thing that patients chart as penicillin allergy is diarrhea, which is just due to GI intolerance. Oftentimes can be mitigated by taking the medication with food. And you'll also see rash, which isn't necessarily an allergy that warrants not prescribing cephalosporins if it occurred with penicillins. There are 4 different types of allergic reactions that you might encounter in clinical practice, but we're only going to focus on type 1 and type 4 briefly today. Type 1 reactions are the most concerning just because they include anaphylaxis. These reactions typically occur in minutes to hours, so relatively quick. And patients who have true anaphylactic reactions will need to avoid beta-lactams, excluding aztreonam. Type 4 reactions tend to be delayed from days to weeks before the onset and manifest as kind of like macropapular or morbilliform rashes. They're generally much less severe than type 1 reactions, but they can be very serious if it develops a Stevens-Johnson syndrome and DRESS, which is drug-related, and eosinophilic and systemic symptoms. The important thing to remember when patients who have penicillin allergies present is that getting a patient history is the most important thing. And oftentimes, if it's charted as a penicillin allergy, it may not be, and it's misrepresented. Asking them the questions that we talked about earlier can kind of help you determine whether or not it's safe to prescribe a cephalosporin in these patients. The last thing I have for you in this presentation is a case. So a 15-year-old female presents to clinic with the chief complaint of a sore throat and fever. Her vitals show a fever of 100.5, weight of 50 kilograms. The physical exam showed nothing really significant except for redness of the tonsils. The allergies are to penicillin, reported when she was 4 years old as itching. Your options to give this patient, assuming the dose is correct for each, would be penicillin VK, piperacillin tazobactam, ceftiofur, or ertapenem. So what should we give her? Well, the first is that we need to diagnose her before we can decide on treatment. Her symptoms are very consistent with strep throat, so we could do the rapid strep test and culture to determine if that's what she has. And for the sake of this case, we'll say that she's positive for strep throat. The next step is to consider what agents have good strep coverage. We know that penicillin has excellent strep coverage, and the VK formulation is oral. So we might consider that, but she does have a penicillin allergy listed. So let's see what the other options are. Piperacillin tazobactam is our extended spectrum beta-lactam, beta-lactamase inhibitor combination that definitely would cover strep, but it is a little bit overkill because it's so broad spectrum and IV. So then that would leave us to pick either A or C, ceftiofur. For the sake of this case, we'll say that we clarified the patient's penicillin allergy, and it is a real allergy. So instead of re-challenging this patient with penicillin, we should just go ahead and choose the safe route of option C, ceftiofur. Appreciate you listening to the presentation, and we're excited to see you in person on class. Come with any questions you might have, and we'd be glad to answer them.